Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. For the record, Sally Hernandez Pinheiro will be participating virtually in a listening capacity. I would like to propose a motion to adopt the minutes of the Finance Committee held on January 8th, 2024. All those in favor?
Aye.
Any opposed? So the motion is adopted. Next, we have a financial update of the HERC program, which Dr. Long is here to talk to us about.
Yes, thank you for having us today. So we have a single slide for our financial update, and then we're going to go into two proposals today. So to take a step back here for a moment, back in October of 2022, the city needed us to move at emergency speed to fulfill our important commitment that no child coming to us with an asylum-seeking family would ever sleep on the street. We have fulfilled that commitment through incredible hard work, 7 days a week, 24 hours a day. But we needed to move at emergency level speed initially, so we used emergency contracts to do that. Also, there was no blueprint or model for this work before we started to do it, so we built a structure brick by brick, with each brick being one of the different types of services. So we had a brick for security, a brick for the hotels themselves, a brick for laundry, a brick for everything we needed on sites. And today we're going to have the two final bricks that compose our overall building or model, if you will. A brick for the administrative support that we need to operate the sites, and a brick for the medical services, which we've uniquely led the way across the country in terms of how to provide to people coming to our country looking for a better life. So I'll give a little bit of a financial update here, but I just wanted to make the point that we've gone out to RFP for every single one of the services that we provide on site. And today is the results of the final two RFPs for the final two bricks for the model that we built to help. So overall, just to contextualize, we currently operate 15 HERCs or humanitarian center sites. We have about over 24,000 daily guests in those sites that we take care of at the sites that we operate. We have been able to help over 115,000 asylum seekers served at the Arrival Center, which is our 24/7 site that all asylum seekers coming into New York City come to each day, that we opened in this past May. H&H has committed $465 million of HERC expenses on behalf of the city in Q2 of FY24. In January, H&H participated in a citywide asylum seeker PEG, which achieved $1.7 billion in savings across FY24 and 25 citywide. Savings were derived from operational efficiencies at HERCs, reduced service costs, transfer of costlier sites to nonprofit providers, and revisions to the asylum seeker census forecast. In H&H's HERC January plan funding, the summary is in FY24 a total of $1.7 billion, and FY25 a total of $1.8 billion. As I've said before, OMB has provided H&H with revenue to cover committed expenses to date through the HERC MOU with the Mayor's Office, and remains committed to continuing to cover all HERC expenses towards FY24 and FY25. So with that, happy to pause and answer any immediate questions before we go into the final two bricks.
Any questions or comments from committee?
Just one quick comment, which is just to commend your team for all the. I know this must be overwhelming in many ways, but I've seen you operate over the last, few months and a couple of years, I would say, on this, and it's very impressive.
Thank you. It makes me proud to be on H&H's mission to provide care in a variety of ways now to all of those in need coming to our city.
Putting those last two bricks in, right, to complete the building. Just one quick clarification, the number that you have in this chart, the 1.7 and the 1.8, that's H&H's budget for the HERC spending, is that correct?
The city put up for us. Yeah,
For us in the January. Okay, thank you. Any other questions, comments? No, great. So then I think we have a couple of action items, the first two related to HERC. So I don't know if Dr. Long or Mr. Keeley.
Sure. Happy
Okay,
to.
great, thank you.
What we're seeking here is authorizing New York City Health and Hospitals to execute contracts with Rapid Reliable Testing, NY LLC, DBA DocGo, MedRight LLC, DBA MedRight Urgent Care, and Cherokee Nation Management and Consulting LLC, and SE Group LLC, DBA the Temp Positions Group of companies, For HERC site administration staffing services at a not to exceed amount of $192 million for a contract term of 1 year and 2 6-month renewal options exercisable at the discretion of the system. So these site staffing, it currently provides 24/7 operational support at all of our HERC sites and the arrival center that Ted was just describing. So these types of tasks are things like badging guests in and out as they come in, handling things like lost and found, handling things like line management. This is sort of the non-clinical administrative activities that happen within a site. They also help get people connected at certain times where they support short-term initiatives like federal work authorization clinics. When there was a sprint to get many people signed up for work authorization, they were helping to do outreach, door knocking, engagement with folks as they come through the front door to make sure they knew that those resources were becoming available. So these administrators help to serve as sort of all-purpose supports in addition to their core functions, their core administrative functions. These vendors hire and manage those staff, ultimately reporting to the H&H manager on site. As we've discussed numerous times in this venue, one of the core tenets of our structure is that there's a health and hospitals manager and supervisor at every one of our sites 24/7. And so the administrators here, the vendors have their own supervisors. Those supervisors report to H&H on site. H&H is ultimately accountable for the activities at that location for all things, administrative services, laundry, food, security, whatever it may be. Currently, we're using 2 existing contracts with DocGo and MedRight. You see here the historic spend. With DocGo, we've committed $113.9 million through February and paid out $47.9 million. With MedRight, we've committed $94.8 million and paid out $41.3 million. The pricing is hourly, with reimbursement for certain supplies and equipment. You'll see the 2 final bricks that Dr. Long mentioned are administrative staffing and clinical staffing, which we'll discuss next. Currently, they're housed through the same emergency contracts. What we did here was split them into 2 RFPs so we could identify vendors that might be able to specialize in administrative services and also vendors that might separately be able to specialize in clinical services. There's some overlap, but that way we were able to tease out entities that might specialize in one or the other. This RFP was done to competitively bid and bring it out of that emergency scenario into a traditional RFP competitive process. And that MOU that Dr. Long mentioned, the health and hospitals expenses are covered by that HERC MOU with the mayor's office. You see here minimum criteria: 3 years in business, MWBE status or plan, $3 million in annual revenue for each of the last 3 years. You see here substantive criteria. And on the evaluation committee, we had representation from ambulatory care, HERC operations, HERC finance, as well as ambulatory care operations, who've worked in these sorts of administrative settings in the past and brought their expertise to bear here. You see here the overview of procurement, with us publishing or going to the CRC, in December, and then posting to the city record in January. We ultimately had 40 vendors attending the pre-proposal conference with 18 proposals received. In February, the evaluation committee met and proposed to go forward with the top 4 scorers that you see listed here. 2 of the vendors are incumbents here: Rapid Reliable Testing, which you see here marked as satisfactory on their performance evaluation, and on the next slide, MedRight, also an incumbent here marked as satisfactory. All the vendors, the selected vendors here, are priced competitively with staffing titles most prevalent around administrative generalist, ranging in the $43 to $50 an hour range. Incumbent vendors saw active cost-saving measures or no net increase, so it was either staying the same or going down for the incumbents. For the 2 new entities we're seeking to move forward with that are not incumbents, Cherokee Nation Management Consulting and SE Group, you see here some of their background. We're excited to say that Cherokee Nation Management Consulting, that might be a name familiar with you, they recently were awarded one of the case management RFPs that we issued, and the work and the operations with them is getting underway imminently. It's been a very good relationship with them so far, and we're looking forward to expanding our work with them in that case management side and potentially here on the administrative services as well over time. SE Group, DBA to temp positions. You see here highly experienced with HERC work through their contract with the Department of Homeless Services. And by HERC work, we mean sort of working in homeless services spaces, not necessarily directly at the HERCs. And working experience with an arrival center model. Assignment of work, just as our other operational contracts have been, no work is guaranteed. So we're seeking to move forward with all 4 of these vendors, but that doesn't guarantee any work to any of them or any minimum level of work with any of those 4. The work will be assigned based on operational need, their capacity, their financial competitiveness, and we can sunset the work at any time. We can sunset the contract with 90 days notice, and we can reassign work from a vendor. If we do assign work to them, we can pull that work back within 30 days, oftentimes even within 2 weeks, if we see that it's not going well, and reassign that work to another operator if needed. So we have good operational flexibility provided to us under the contract. And then when new vendors are introduced to a site, as I said, health and hospitals managers and supervisors are there overseeing the site. It's juggling a number of different vendors. Food, security was mentioned earlier. So when they're introduced to a site, the H&H manager is responsible for integrating them in and ensuring that it's a smooth transition. We've done that a number of times and feel confident that we'd be able to do it again with these new entities. You see here the vendor diversity targets, utilization goals, 35% for each of them. You see primarily it's supplemental staffing is the primary space where the utilization would be achieved. So we're seeking approval to enter into contract with those 4 entities I mentioned to provide site administrative services at a not to exceed amount of $192 million, with a contract start date of April 1st, 2024, with a term of 12 months and 2 6-month renewals, optional. And as we said at the beginning, all of this is covered by the HERC MOU with the Mayor's Office.
Great.
Thank you.
Thank you, Chris. Any questions or comments?
No questions.
No questions.
Great. I just have one comment, or 2 actually. The first is, and it's terrific that we are now getting to all these RFPs and getting through them. We started in emergency contracts, et cetera. I noticed on the cost analysis page, you said we were seeing cost-saving measures, which is terrific, or no net increases, which is also good, because I think some might say, well, why aren't we seeing absolutely decreases? But I think that is a testament also to our ability in terms of during the emergency on how to secure services competitively. Is that?
I think that's right. I think that the emergency contracts there were built off previously competitively bid contracts, right? So when we were doing the emergency contracts, we were able to look to and lean on prior competitively bid contracts. Not that it was precisely the same work, but it was comparable types of administrative services, and we could look to those to bring competitively bid pricing into those emergency contracts, and that's why we're not seeing a big spike or drop in these, that those original ones actually had relatively competitive pricing.
And then getting a diverse array of vendors that can help and be more specialized in the specific work, breaking these contracts apart. I think it's terrific. But it also goes to show that what we were doing before was also very well managed. So appreciate that. I think another point that I just wanted to highlight, which came up a couple times in your presentation, is having the H&H managers on site and then being able to manage the different needs at different sites, and having the variety of contractors and having the flexibility to move them around and change them, I think is all very well thought out. Thank you.
That's right. And that also leads to one of the sort of cost savings measures that Dr. Long was talking about. By having those managers right there on site, we can help to drive changes in headcount, changes in footprint, efficiencies in how the sites are managed. And that's where we've been able to gain a lot of the measures. We have our own folks right there on site 24/7, so we can identify sort of when there's downtime and how to make better use of it, when we might be able to gain efficiencies in reducing headcount at certain sites. So that sort of model of having our folks on site, we've found really valuable.
Just a quick example of that too is with food services. I think, as we've talked about before, we've gone through great lengths at a cost zero strategy of doing surveys to see what types of meals people would want and be able to bring meals that people would not only enjoy but actually eat. And working really hard on this and monitoring what people have been eating, which we continue to do every day. We've reached a 98% food consumption rate,
Wow.
meaning almost every piece of food that is given out is nutritional and enjoyed and eaten by all of our guests.
That's terrific. Great, thank you. So if no other comments or questions, I'd like to propose a motion to move the resolution forward to the board.
So moved.
All those in favor?
Aye.
Aye. Any opposed? Oh, great. The resolution's adopted. I think the next one is also you, Mr.
And I
Healy.
think Dr. Long may kick us, well, I'll do the first slide and then pass it over. So this one is for authorizing health and hospitals to execute contracts with MedRite LLC, DBA MedRite Urgent Care, Rapid Reliable Testing, NY LLC, DBA DocGo, Acuity International LLC, and RCM Technologies, DBA RCM Healthcare Services, for HERC clinical staffing services at a not to exceed amount of $211.3 million for a contract term of 1 year and 2 6-month renewal options exercisable at the discretion of the system. So for context, Dr. Long can frame us up, I think.
Thank you. And to contextualize this, healthcare is a human right, and that's a core part of our mission at Health and Hospitals, and I think has been one of the strongest aspects of New York City's response to the asylum seeker crisis now, the situation of at more of a steady state, having people continue to come to our city for help each day. But going back to the beginning of all of this, we came at this initially with preventive measures in mind. For example, we ran the test and trace core, so of course we tested everybody for COVID. But we've learned a lot in this journey about the healthcare needs of asylum seekers. And in particular, we had a few cases that we saw that really affected us and really were emblematic of the types of situations people would be coming in with and what we needed to do in order to help them. We had a child with a witness seizure at our feet because his medication was taken away at the border and he had no way of getting another anti-epileptic before coming to New York City, where we saved his life, put him back on a stable regimen. We've had women in varying stages of pregnancy, including we've seen several women that had their first prenatal visit at 9 months at the arrival center because they were not offered prenatal care anywhere else. We had a woman that came in labor, and we brought her to the hospital, and she delivered a healthy baby that same day. So when we brought all of this together, it enabled us at the arrival center to really take to really build a model that was structured around everything that we'd learned. It was efficient, but was specific to the needs of asylum seekers. So just to walk through right now, for example, for the over 115,000 people that have come through the front door of the arrival center, they've all first been screened for communicable disease, COVID, varicella or chickenpox, and active tuberculosis. They all are offered urgent care visits, including women that are 9 months pregnant, which we regularly see at the arrival center every day, or people that have had their chronic disease medications taken away from them, or they haven't had an opportunity to renew. We then screen everybody for depression, acknowledging the trauma people have been through. But again, that's a specific service that we want to offer up front, a matter of minutes after you get into our city, because we know that's what it could take to save your life, to address your mental health up front. And then we offer everybody vaccines. We've administered more than 60,000 vaccines to asylum seekers, 6,000 doses to asylum seekers at our arrival center and our humanitarian centers. So what we're about to show you is really how to continue the approach that we've taken, which is grounded in our experience caring for asylum seekers and everything we've learned to date. And the final point I'll just make is that that's everything we do at the front door up front. But then we've also made a concerted effort to connect people into ongoing longitudinal care in our system. And we've completed nearly 100,000 visits at H&H alone for asylum seekers, continuing to give them life-saving medications, vaccinations, mental health, and really connecting them into care that they could have for the rest of their life. So with that, I'll turn it over to Chris.
Thanks. So these contracts are a way to continue building on that great success we've had so far, being able to provide those services, and again, bringing the contracts out of an emergency scenario into a competitively bid scenario, and breaking apart that emergency contract that had both clinical and administrative services together. This is the other half now, where we broke it apart, and this is the clinical services half. So we're seeking vendors to continue providing those services. Currently, we're using DocGo and MedRite. The historical spend here since October, you see DocGo, we've committed $144.9 million and paid out $64.9 million. With MedRite, we've committed $36.3 million and paid out $11.4 million. Pricing is hourly with reimbursements for certain supplies and equipment. There's no ancillary cost. And as with all RFPs, these are covered by the HERC MOU with the mayor's office. Minimum criteria here, you see 3 years in business, performing similar clinical services staffing, MWBE status or plan, $3 million in annual revenue. You see the substantive criteria as well as the evaluation committee listed here, which involved folks from ambulatory care, HERC, both on the finance and medical, clinical, behavioral health sides. So for procurement here, we went to the CRC in December, posted to the city record in January. Ultimately, the pre-proposal conference, we had 28 vendors attending and received 21 proposals in the end. In February, the evaluation committee met, and we're seeking to move forward with the top 4 scorers that you see listed here. Medright is an incumbent. As discussed, their performance has been satisfactory. Rapid reliable testing, the same. And Acuity, we did some work with them during the test and trace days, particularly during the Omicron surge, and performance at that time was satisfactory. For the cost analysis, we looked at proposed hourly pricing titles for each area of the contract, right? So I didn't tease out at the very beginning there. There's sort of 2 sub-bodies of work here. One is physical health, and then the other mental health and casework services to support that. And so we did side-by-side comparisons, understanding the price competitiveness across the vendors. All selected vendors are priced competitively. For example, here you see a Master of Social Work. Billing rates all ranged within 80 to 95. As we'll discuss later, and with the other RFPs we've brought here, everything is competitive here. So even if we were to move forward with these 4 entities, the assignment of work can still be influenced by trying to lead more heavily on those with the $80 mark as opposed to the $95 mark. There's always opportunity in the future to go to those at the $95 mark and try to amend in the future, bringing down their price so they get more cost competitive to get additional work if we see that Master of Social Work, for example, is going to be an area of growth where we need some more support. So we saw with the incumbent vendors, active cost-saving measures or minimal hourly changes. Certain roles such as registered nurse, very competitive markets out there, so there needed to be modest changes on those. And then to offset certain increases, incumbents also saw reductions in certain non-clinical hourly lines, such as caseworkers that are there to support the social workers. Vendor background here. Acuity, you see 47 years of experience providing clinical services, and they've done it in these types of settings. RCM Healthcare Services, 45 years of experience. They've been in similar types of settings in the past as well, including with New York City Administration for Children's Services. Assignment of work, as discussed on the last RFP, and with this one, it is the same, no work guaranteed. We can terminate contracts, 90 days notice. We can reassign work on 30 days or less, I'd say. Vendor diversity. We've got targets here of 35%. Again, similar to the last one, you see that largely concentrated in the supplemental staffing area. That's where the vendors will largely be focusing their work to hit those targets. So Office of Ambulatory Care is seeking approval to enter into contract with those 4 entities to provide clinical staffing services at a not to exceed amount of $211.3 million with a contract start date of April 1st with a term of 12 months and 2 6-month optional renewals. And again, all expenses under here will be covered by the HERC MOU with the Mayor's Office.
Thank you. Any comments or questions?
Nope.
No. Great. This one is, of course, very dear to us because of the medical services component. So thank you, Ted, for the context and background. The one clarifying thing, I just want to make sure, the historical spend, there was a comment that we committed a certain amount to the existing. Just want to make sure that that commitment sort of ends with the new contract starting. Is that, so what's unused under that commitment? Is that?
That's correct.
Okay, great. Thank you. Terrific. Thanks. I'll take a vote. Motion to approve the resolution.
So moved.
All those in favor?
Aye.
Aye. All those opposed? Thank you very much. The resolution is passed.
Thank you for your support.
Thank you. Next, we have Mr. Chung, I believe, who, is that right? Yes, there he is. Okay. I didn't know where he was.
If it's okay, while he's coming to the table, can I just
Sure.
lead off? He is,
Yes.
David is our Deputy Counsel and fearless lead of the Claims and Litigation Division. So this first one is a contract for a new TPA or third-party administrator for our many med mal claims. I just wanted to make a couple of points. First of all, this unit has done, as you'll see in the presentation, just an amazing job along with the quality in our system, we hope. Not that all med mal is connected to quality, it often is not. But our med mal expenses have just really gone down, down, down ever since it's come to H&H, but even very significantly in the last few years. And credit to David and team, having a really tight administrative structure is very critical to that. So the TPA is a very important contract for us. But I also want to say, when I first came, we had a TPA arrangement that we've had for a long time. And the one challenge that we had is it was extremely difficult to extract any data that was usable for thinking about, where do we have a lot of claims, or where might we develop some interventions to kind of address particular issues. It was very hard to extract data, and it's been a long wish of mine that we could do that better. And I do think you'll find out from David that one of the great enhancements that we're expecting in this one is that we will be able to actually have a new data system that will allow us to hopefully get some insight out of not just have them do a great job, sort of with what lands on us, but also hopefully be able to get some insight out of where some of our liability costs are coming from in a more significant way. So anyway, and take it away, David.
Thank you.
Good morning, everyone. This is an application by the Office of Legal Affairs for medical malpractice claims management services. We are seeking authorization to award a contract to Gallagher Bassett, which provides medical malpractice claims management services on behalf of the system for a total of a 5-year period, initially 3 years plus 2 1-year options to renew at a not to exceed amount of $35,850,000. So the Office of Legal Affairs handles at any given time about 1,500 to 1,600 different matters, and typical of hospital systems similar to H&H. We use a TPA, a third-party administrator, to help manage the volume of claims and also the medical malpractice costs. Two of the largest components of the medical malpractice costs include settlements and payouts, and also the outside claims legal fees. And if you, looking at the next slide, if you look at our historical costs for these two components, including, which would be slide number 4, please. If you look at the last 9 or 10 years or so, the medical malpractice payouts, with the assistance of a TPA, we were able to bring that down from about 135 million in fiscal year 2015 to approximately 67 million in fiscal year 23. The other component of costs would be outside counsel fees, which is the sort of the second largest component of medical malpractice costs. We've been able to pretty much maintain both costs relatively flat over the same time period, and the TPA costs for the last 10 years or so were flat at $6.14 million, which is the current contract agreement that we have with our incumbent, which expires in August of this year. So we had a TPA, our incumbent, since 2002, and early in 2023, we did a request for information to determine whether other vendors could potentially provide the scope of services that we needed. Based on the responses we received, we went into RFP. The scope of services included early investigation, which is very important to our facilities, the day-to-day supervision of outside counsel, the tracking and monitoring, provision of a electronic database system to track all the claims and litigation data, compliance reporting, indemnification, and tracking expenses. You'll see the RFP criteria on this slide, which the biggest component is has the subject matter expertise in the management of claims, including the implementation plan and technology were critical components of the scoring criteria. Um, Gallagher Bassett was chosen out of a pool of 4 potential vendors, and the proposal is at a bit higher cost, approximately $7 million per year, and some of the advantages that this vendor had over the others was that they were going to use medical malpractice litigators, experienced defense attorneys who would monitor outside counsel tasks, their billing, provide strategies for earlier resolution with the goal of saving costs, using having access to their databases for selection of experts, and also to assist us in negotiating resolutions based on the settlement numbers that they track by venue. They have a dedicated IT technology team that would help migrate our legacy data into a new database system, which, as Andy mentioned, hopefully will help us gain more insight into the data that we actually maintain. We checked their references, and each reference reported that this particular vendor did exceptionally well for them. The diversity team did an analysis and determined that there would be no subcontracting goals, that all the services would be performed by this vendor, and was then able to identify any MWBE entity that could provide the services requested. So the request here is a approval to award a contract to Gallagher Bassett at an NTE of $35,850,000 for a 3-year period. And the proposed contract would allow us to reduce or remove any category of service provided under the contract within 30 days notice. Thank you.
Thank you. Any questions or comments for David?
Gallagher Bassett is the current,
No, it's not. It would be a new one.
would be a new one?
Correct.
So, for the current one in place, because the numbers go down a whole lot, the number of settlement payouts.
Correct.
So, is it, when you give out these contracts, for example, do you have a sense of what that would look like with a new vendor, or?
We're hoping to continue the path towards reducing medical malpractice payouts, and the team that is being proposed, we believe, would sort of provide enhanced services because it will be a team of medical malpractice defense attorneys who have worked in law firms, which is kind of unique to the other vendors, including our incumbents. So we're hoping to continue that path.
But Jose, just to maybe clarify something that maybe this addresses your question or not, they're not actually doing the medical malpractice legal work. They are doing a few upfront sort of investigation services, like right when perhaps an event happens that we hear about, and they're helping to like review bills, they do some administrative kinds of services, and they kind of are like monitoring what's going on with law firm claims, but they are carefully monitored by David's team, and then underneath them the actual legal work is either done by some people on David's team or outside law firms. So they're not the lawyers representing us on this.
Right. The in-house legal team determines what the sort of tries to determine what the most optimal resolution would be, and the claims management piece is more the day-to-day sort of whether the tasks were done or completed on time, and whether they were done within what would be a reasonable budget for those tasks.
Thanks.
So I guess said another way, this TPA might actually enhance that red line getting better, maybe.
Yes, there's many factors, but I think they will probably do
Because they're
that
giving
body of work
additional.
even better
Right.
than what we've had.
Because providing the data that you couldn't have before, and then that they are attorneys that are also.
Right, exactly, doing the monitoring with a higher level of staff.
Great. Any other questions? Nope. So I will propose a motion to approve the resolution? All those in favor?
Aye.
Aye. All those, any opposed? So the resolution is approved to go for the board. Thank you.
Thank you very much.
So terrific. We have some good time to go for the financial update, go through the financial update. Mr. Alberg.
Thank you. Good morning. So we're at the halfway point in the year, and the system is performing well, stable. We're going to close, or we're approximately have 468 million days cash on hand. Actually, it's higher today. We can talk a little bit about that. Closed the quarter with a budget variance of a plus 1%. That's pretty much where we would want to be. And we're seeing continued growth in our volumes for both, inpatient and outpatient services. Healthy volumes there. And then strategic financial initiatives is also running right on target halfway through the year, 573 million versus our target of a little over $1 billion. And again, I think that performance is really, I think, across all the major areas where we, have financial incentive initiatives underway. So all looking pretty good there. Cash, February, closed with 450 million. March, we expect to close around 600 million. We'll talk again a little bit more about our cash situation, and we continue to work closely with the city on a day-to-day basis. Managing risks, I think, continue to improve for us. The staffing glide path, right, that we've spoken about is actually doing, I think, exceptionally well. We're hiring, quite a few nurses across the system through our all hands on deck strategy there. 405 ahead of target by 405 nurses, and we will start to see against the glide path the separation of our contract nurses.
I think we just a shout out, she's not here, to Natalia, who's really pushed on this, both in terms of hiring and making sure that we don't have temp nurses once we don't need them. She's done a great job with this.
Yeah, excellent. Sessional and locum spending, we are seeing increases there against the budget, and we're exploring that with our medical staff. So there's efforts underway there, similar to nursing. Inflationary pressures, right? We continue to watch, our per unit costs and cost in general, growing, but again, we think manageable. City-state budget, H&H released its January plan. We had our meeting with City Council last week. Very happy to hear that there's no additional pegs in this plan. So hopefully the city's financial situation continues to sustain itself. In terms of at the state level, the governor released her budget, and we're anticipating one House bills to be released at some point this week, which we'll take a look at. So at that point, both houses and the executive will have their positions on the budget ready to debate. Medicaid research, we turn that to green, sustained performance above the target of, I think we're running at about 80% research. And then the last one here, right, I'm sure you've read about, in the press, it's the outage related to Change Healthcare, the cyber attack. Obviously that's, hit the entire nation. A lot of activity to address that. For us, it was, and Margie can talk a little bit more, but it was a end-to-end disruption, all the way starting from, the point of running our, contact center to determining eligibility to being able to get claims out the door and remittances. So it was certainly a big attack. Our strategy is, first and foremost to make sure that we have enough cash in the bank. So we have a 6-week window at this point that's, we're very confident in. We have $1 billion or nearly $1 billion in the bank, today. So we have a clear path forward for the next 6 weeks. Plan B is us working with our partners at the state. We have certain UPL funds that have already been approved by CMS that are in the queue. They just need to execute on those payments. That would probably carry us another 6 weeks. And then if we had to even go further than that, we've been having communications with CMS about things that we have with them for approval. And you've heard us talk about, you know, the outpatient UPL, and then there's a FY '23 fee-for-service UPL that we're trying to sort through. I wrote them a note last week, and they immediately responded, so we're on their radar. So we feel pretty good about securing a cash position to buy us some time to implement, you know, some new changes. And I'll turn that over to Margie. You want to talk a little bit about that?
Sure. So we are one of the providers that were hit, as John said, end to end, because Change Healthcare is our current clearinghouse. So all of our claims out, all of our payments in are impacted. We haven't gotten a claim out the door except to Metro Plus, which we do bill directly. We don't go through a clearinghouse. So we've been feeling really fortunate about all of these cash mitigations so that we didn't have to do a plug and play solution really quickly, which would have had us plug into a claims clearinghouse, which you can do, I say probably inside of a couple of weeks.
You
Which
mean a
would have
different
gotten
one?
claims out,
Yes.
but was, you know, with a third party claims clearinghouse, we would have been able to send claims to the payers, but then we would have been sort of blind to what happened next. So the clearinghouse solutions that we have in place give us insight. There's a bidirectional interface that gives us insight to what happens to the claim, so we know if it was acknowledged by the payer, if it needs a correction, if it doesn't need a correction, what that correction is. So this has bought us the time to do this like really planfully and thoughtfully, as opposed to some of our colleagues, which really just needed to push the claims out quickly. We reached out to the vendor whom you generously approved a couple of months ago to expedite our implementation of Experian, which we have done, and we expect we will have claims going with many, not all payers, but many payers, and certainly our top 10 payers by April 15th. We will have Experian up and running, and we'll have insurance eligibility solutions in place. There's sort of a couple of phases of integration. So one is not at all integrated. That should be up and running, I'm hoping, by the end of this week, where it'll be a single platform for end users to go in and check eligibility, as opposed to now, to do it manually, they need to go into each and every payer's website, which is almost unsustainable is unsustainable at the front end. So this will at least give us a single portal to go through while we're developing that electronic integration, where they can take our eligibility files and return a response. So that's also up and running. So what was expected to be a July 1st implementation will be in phases. Now, we were going to go big bang July 1st, now it'll be in phases, starting around April 15th for claims, and then building up to what would have been the optimal and you know, full suite of products, and we'll probably be live closer to June 1st, fully live closer to June 1st instead of July. So that's where we are.
So, then we won't be with Change at all anymore? We'll be moved all the way to, over to Experian? Is that?
Still a little unclear. So there's a couple of things. One is I didn't address our remit files. Change still has a whole bunch of our remit files that were in play, or those that have come in since the outage on February 21st. We do need to get those from Change, so we will need to reestablish connection with them. And enrolling with payers for remittances is a little bit more complicated, and we will likely turn Change back on for all of our remittance files until we're sure that we can comfortably and completely change over to Experian for that. The other thing is that starting on Thursday or Friday of last week, United was saying that Change will be back live for claims, for remits, maybe starting to test on this Friday, and claims next week or vice versa. And we have a decision to make. And so we're getting together with the IT team to get together and decide what we want to do about that and how we approach that. We could turn back to change if IT and security is fully comfortable with that and move back to plan A, which was, take our time with the Experian implementation, or we can, we've started the work for Experian. Do we just,
But for the gap between February 21st or whatever till, let's say, April 15th, when you can get most of the stuff online with Experian, you're going to have to still reconcile that part, right? I mean, with change, you can't, Experian can't step in and do what was, or can
for
they?
claims, we could just turn right to Experian. We could just, even if change had it in the queue,
Right.
we don't know if they're ever going to be able to reconcile what they did and didn't send. For that period of time that the outage started, we expect that they're not going to be able to 100% reconcile. Similarly, with our statements to patients, which also run through Change Healthcare, we've been talking to them about it, and there's this little window that they may never be able to know, like a small segment, but did this actually get sent out or not? So we're going to, I'm sure, err on the side of caution, and any claim that we're not sure about, we'll resend. We do have, New York State did publish a directive, it's called a circular letter, the Department of Financial Services, instructing insurers in New York State for any provider that certified that they were interrupted due to change, which we are certainly one of the most impacted. And we have so certified to our insurers. We'd already sent letters to them, and now we're filing these certifications that they are to waive things like eligibility requirements, prior authorization, notice of admission, and tolling requirements like timely filing requirements and requirements for the tolling requirements on appeals. So that buys us the time. And again, with these cash flow mitigations that the team has really been working hard on, has really bought us the time to do this thoughtfully, planfully.
So I think, John, I heard maybe 12 weeks we can
Yep.
sort of
Yep.
get through.
And we don't intend to take 12 weeks to start billing. We do not want to use that full ramp up.
Right.
And we've been working really hard. And we spoke to vendors other than Experian. If somebody was able to do this faster and more completely, it was not our choice to go to a third vendor, but
Right.
we would have done that. But this seemed to be the best plan to get us
So-
live and running
Yeah.
in the most comprehensive way.
Great. And I read somewhere, is CMS, or are they maybe potentially advancing money too if necessary? Right,
Yes,
so
we're
there are
gonna
other,
more about that through the Medicare program. But I think, I have to applaud both CMS and DFS. I think CMS laid out, the framework of their expectations, signaling to the insurers like this would be our preferred behavior. And I think DFS took that guidance and now has, put it into operation. And we just received it Friday, where
Yep.
there's an attestation process that we would have to go through. But, all the different waivers and
Yeah.
timely filing, again, we appreciate that.
Right. I don't want to take up a lot more time here, but we're moving to a new vendor, which is great, but the new vendor is also, can be vulnerable. And so just thinking about how these things, how do we protect against these things? It's more probably an IT discussion than.
Yeah, though I will say that we have on the list to deal with after we get live is what does redundancy look like? And I spoke to a bunch of colleagues about that, and I'll say the answer is unclear because without multiple contracts and,
Right.
so.
Yeah, we're certainly not alone in this. I mean, this
Right.
is an industry-wide.
So very much to be determined.
And I'll say, I think our capitation relationship with Metro Plus
Plus.
and Health First helps a lot too.
Right.
And they've both been, helpful in terms of advancing school payments to us if we need it. So that's,
Right.
helps us get through COVID. It's gonna help us here again.
And Health First is not direct pay, right? That one, it's just Metro Plus where we're direct. Is that-
Correct. Health First, we go through the clearinghouse.
Great.
But there's options there for us to explore too, right, in terms of other providers that we may.
Yep.
Yeah. But I think redundancy is the lesson being learned here.
Right. And fortunate that your cash flow management is keeping us,
But you've heard me complain a lot about lump sum payments and how much.
right
we
now
don't
it's
like
helping
them and How
us.
they're okay.
Yeah. The lump sum came at the right
Yeah,
time,
right,
I
exactly.
guess. Yeah.
Yes.
All right, well, thank you for the update, and I know this is very stressful, so it makes me feel better sleeping at night that you guys are on it, so thank you.
Sure, I'll walk you through the next few slides here. So again, we ended year-to-date December with 1% positive margin, driven by, again, continuing revenues coming in above target, while expenses are also coming in above target. We'll go through the details on the next slide. So on the revenue side, you can see that a big piece of our overage on the budget performance is coming from the risk pool. A lot of it is driven by the PMPM coming in higher than what we anticipated, particularly on Medicaid and Essential Plan. We have other revenue that's coming in above target with 340B. Again, that's just a timing of a budget modification to align with updated targets from the pharmacy group. We also have our inpatient and outpatient billing coming in really close to target. We're slightly ahead of target on discharges, offset by rates being slightly down. And again, we have some cash performance coming in above target, and some of that is physician billing. We're doing better than budget. Questions here? On the expense side, we're continuing to see that agency spending is over target, but to John's point earlier, we did see a big drop in our temps in January, and so we expect to see that cash improve in the coming months as we start to see that we're not paying for temps anymore that are coming off. Affiliation spend on sessional and locum ahead of target. Again, there's glide paths being developed to address ththose issues. PS, and OT, most of that is overtime, particularly in the trades and EVS. So there's work being done with OFD to kind of figure out what's happening there and what needs to happen going forward. And then our other discretionary spend is still ahead of target, primarily driven by pharmaceuticals and med-surg supplies. So here you can see a snapshot of the year-over-year comparison. So FY24 direct patient care revenue is 170 million better than last year. Increases year over year are attributed to a few things. We did get a healthcare workers bonus, approved state Medicaid increases. Our UPL is coming in, allowing us to beat last year's targets, and then an overall increased volume and cash performance in our rev cycle initiatives. Any questions?
This is good slide. I like your purple slide.
Yes, we like the purple slide too. We slip it back in every once in a while, but it does give you a nice perspective, right? Looking at the actuals versus the budget, and it continues to sustain.
Visits up, CMI up.
Yep.
What's the healthcare worker bonus? That's
It was just a Medicaid bonus that came in to pay healthcare workers, so there was a expense on one side and a revenue on the other side, but we didn't get it last year, so.
It's from the state. It was part of a state initiative post-COVID.
thank you.
About 23 million so far.
Great. Thank you.
So I think very quickly, we just had our informational item, which was our January 2025 financial plan, which John noted. We released in early February, and the city council hearing that Dr. Katz and John were at was last week. So just to have a quick rundown of our 5-year picture, it's very similar, I think, to what we've had in recent years. Importantly and excitingly, we're currently projecting positive income in fiscal year 24, about $69 million, which was better than we've been the last couple of years in the current year at that time. So hope to keep that up. A lot of good revenue that Salima just walked through is a big reason for that. We are projecting small operating losses in the coming 2 years of about $50 million each year, which is quite small, and it's something that we can manage as we get into the current year. but we are facing a few cost pressures as well as needing to reduce a couple, timing and amounts of revenue assumptions. But over those 3 years, we are looking at anywhere from 715 to 815 million as our closing cash balance each year, which is pretty robust and strong for how we've talked about it is between 25 and 30 days. So, we hope to stay there and, with the stability throughout the period. And even if we get more timely with certain payments, that should be very good. We do, face a few challenges as we get into FY 27 and 28. We see that the losses grow. Again, not unlike past plans, but still something we need to monitor. And there's just some cost pressures, that we're working through on those. And we do, of course, have our large strategic initiatives that are meant to offset that and that we'll continue to implement. Part of the reason for, the losses we see are the federal dish cuts. But we are working with some of the growth in our, especially our supplemental Medicaid initiatives that John talked about, the inpatient and outpatient UPL conversion. That helps mitigate to, a large extent the impact of those cuts were they to happen. And then, there are just additional things we continue to look at, like our collective bargaining agreements and things like that, specifically with NISNA that we just need to work through as we get to those outer years. But, all in all, I think our plan feels strong and, in line with where we've been.
Anything, John, did you want to, anything, I see there's a few things in the appendix.
We just put those back there for you because we reported on them before. But, the research performance is been doing great. Got through December-January period, which was, we thought, going to be a tough couple of months. And then on 17 shows the work of what Natalia and team have been doing with, substituting our own nurses for contract nurses. Again, great performance there.
Thank you. Dr. Katz, any? Sorry, got you when you took it.
No. I mean, I was just thinking what it means for us that we have an organization where a 1% variance is $70 million. But we have a very competent team, and they do a great job managing it for us.
Thank you. Yeah, I echo that, of course, and appreciate the update and terrific work, and look forward to hearing how the budget goes.
Yes.
Thank you. So is there any old business? Any new business? There being no further discussion, meeting adjourned. Thank you.
Thank you.
This meeting is no longer being recorded.